always am eager to talk about what should be done. But this morning, I'm mainly going to be talking about the sources of our present situation rather than the solutions. Early in 2016, the publisher of my 1982 book, Social Transformation of American Medicine, asked me to update it for a new edition, which forced me to try to make sense of what's happened in healthcare during the past 3.5 decades. So that original book presented an analysis of the development of the medical profession and healthcare from Colonial Times up to the beginning of the 1980s. And the epilogue I've written, which is really 3 separate chapters, picks up the story from where I left off in 1982, focusing especially on changes in the healthcare industry. Those changes, however, can't be separated from the overall political context of our time. And so I write at the beginning of the epilogue, this has been an era of wrenching social divisions and deep public distrust of institutions, and healthcare has not escaped the hostilities. In many countries, health policy is a specialized topic discussed mainly by experts. In the United States, it has become the focal point of partisan warfare and rocked national politics repeatedly. With more than 1/6 of the economy devoted to health care, the interests at stake are enormous, the moral interests as well as the economic ones. Despite spending far more on health care than do people of any of the other advanced industrialized countries, Americans still lag behind their peers in measures of health, and marked disparities socioeconomically in health and medical care remain. While medical care has made striking advances, and we can be grateful for that, the system for providing and paying for care has become more complex and constraining for both patients and professionals. No reasonable person would trade today's science for the knowledge of even 5 years ago, much less 50. But many would trade today's rules and arrangements for what they remember or imagine was the simplicity of another time. Now, this contemporary climate of public distrust and political division forms the backdrop of developments in healthcare over these recent decades. But the driving force of the last 35 years, indeed of the last 50, has been the explosive growth in costs, which has set off a series of chain reactions in healthcare. And this epilogue of the book is built around this idea of a series of chain reactions that have worked their way through the healthcare system. And these chain reactions have followed the following pattern. So I'm going to give this to you first in 5 very abstract steps. 1, the rise in costs has spurred the adoption of a series of new methods of financial control by government, employers, and health insurers. And 2, the new methods of control have set off cycles in the insurance industry with the introduction of new forms of coverage, HMOs in the 80s and 90s, high deductible health plans more recently, that do achieve some economies, but flourish particularly because they enjoy favorable risk selection, typically to the disadvantage of older, more generous types of coverage, which then get driven out of the market. And then 3, pressures from payers have led to increased consolidation among providers, affording greater market power to the strongest among them, and enabling them to drive up prices, one of the main reasons for the higher costs of healthcare in the United States compared to other countries. And 4, this continuing rise in costs and long-term erosion of job-based coverage, along with endemic problems in the non-group market, have created a persistent crisis of affordability and led to periodic campaigns for expanded public programs. And then 5, changes in finance, organization, and politics have then variously led to popular anger, professional resistance, political backlash, and intensified ideological and interest group conflicts, sometimes producing counter-reforms and churning through a series of different innovations for which there have been waves of enthusiasm and then, alas, disappointment. Now, over these past 35 years, these processes have unfolded in what I characterize as two great cycles of institutional change. So the first cycle ran from the early 80s to 2000, and it saw the rise of managed care and its partial retreat. The central idea in cost containment during that period was putting providers at risk, and the prototypical innovations were managed care plans of various types, especially HMOs. The prototypical reform campaign of that era was the effort that I was involved in, the effort by Bill Clinton in 1993-94, with its emphasis on managed competition as a basis for both universal coverage and cost containment. The prototypical reactions of that period came first against the Clinton plan, and then in a more general backlash against managed care in the mid to the late 1990s. But the second cycle, which is still ongoing, began right around the turn of the century, and has seen a struggle over risks, over risk shifting. Who's gonna bear risks? And just as the central idea of the first cycle was putting providers at risk for costs, so one of the central ideas of the second cycle has been putting consumers at risk for costs. Just as the HMO epitomized the first cycle, so the high deductible health plan has epitomized the second cycle. And while some changes have aimed at making consumers more cost conscious about their choices, there have also been countervailing efforts to limit the risks and the burdens that individuals face. So just as the struggle over the Clinton plan punctuated that first cycle in the late 20th century, so the struggle over the Affordable Care Act has, in a sense, punctuated the second cycle, with a great difference, of course, being that while the Clinton plan failed, the ACA was enacted, although its ultimate fate remains unclear. So in their cumulative impact, these two cycles of change have swept away many of the institutional legacies of the past. If you go back to the early 1980s, HMOs, for-profit hospital chains, and various other enterprises were on the rise, but really the traditional forms of organization continued to be the norm at that time. The overwhelming majority of physicians were, at that point, still self-employed. Most hospitals were still freestanding, independent nonprofits. Most privately insured Americans had coverage that paid for care on a fee-for-service basis and included no restrictions on the choice of provider. Those were still the norms. The spheres of medical practice, hospital care, and insurance remained largely separate and discrete. Hospitals didn't employ lots of physicians or own medical practices. Insurers interfered very little in with medical care itself. Now, all this has changed. That separation of medical practice and hospital care has broken down. At the local and regional levels, the healthcare industry has become much more consolidated, horizontally and vertically. And although the aims of so much reform have been to stir up market forces, what those reforms have ended up stirring up is concentrations of market power. That's the reality. Despite all the reforms over the past 35 years, healthcare costs have risen to far higher levels than anywhere else, and the crisis of affordability for both consumers and government remains. As a result, the underlying pressures for institutional and political change persist. And there's no reason to believe that we have reached any kind of stable equilibrium in health policy and healthcare organization. Now, before saying a bit more about this series of chain reactions, I'd like to step back and suggest how they fit into the sweep of history that led up to this most recent period. So, The Social Transformation of American Medicine, even though it was published in one volume, actually has two books. There's a book one, which runs from the colonial period to the early 20th century, and that's fundamentally about the rise of what I described as professional sovereignty. In fact, in the early 1800s, the authority and power of the regular medical profession declined as competing medical sects developed. States repealed early licensing laws, and the medical marketplace was thrown wide open. This is in what's known as the Jacksonian period, 1830s, 1840s, 1850s. But in the late 1800s, and especially during the progressive era at the turn of the 20th century, the medical profession succeeded not only in restoring its authority and licensing protection, but also in shaping hospitals, limiting the scope of public health agencies, and keeping at bay various kinds of corporate organization that might potentially have subjected physicians to some kind of organizational control. And book one ended with the chapter, Escape from the Corporation, about why physicians, in contrast to so many other occupations and professions, preserved their individual autonomy and limited the power of organizations, power of management, in effect. Book two traced what happened to professional sovereignty and with the growth of healthcare into a major industry in the 20th century. Well, the first part of that story is that from around the time of World War I, physicians, together with other interest groups, successfully defeated the enactment of public programs of general health insurance. And as a result, there grew up instead private systems, largely private systems of healthcare finance and organization that accommodated provider demands, which effectively meant they didn't impose any real cost control on the system. That pattern of accommodation and of provider interests persisted even when the government finally assumed a larger role in medical research and hospital finance after World War II, and then in the financing of services with Medicare and Medicaid in the 1960s. But in the 70s and 80s, a counter-movement began to take shape as the public lost some of the confidence that it had in the medical profession, became more skeptical about existing organization, and new modes of control emerged, at first in the form of government regulation and then increasingly in the market. And in direct contrast to that last chapter of book one, Escape from the Corporation, the final chapter of the book was about the coming of the corporation to healthcare as of the early 1980s. But really, while these new modes of organization and control were developing by the early 80s, they were pretty weak and limited in scope. HMOs had only a tiny share of the market. Most of the corporate growth at that time consisted of the expansion of hospital chains and other enterprises that were seizing the very lucrative opportunities of a lax payment regime. At the time my book went to press in 1982, Medicare still followed the practice of retrospective reimbursement of hospitals according to their costs, and payment of physicians on the basis of their usual customary and reasonable fees, methods that had dramatically raised prices and costs throughout the healthcare system. But that very moment in the early 80s, coincided with a number of changes. Congress authorized the introduction of prospective payment for hospitals. California pioneered legislation allowing insurers to contract selectively with providers to get hospitals and doctors to bid against one another for business. In Arizona versus Maricopa Medical Society, the Supreme Court ruled that medical societies could not bargain collectively with insurers. Now, these were all key developments in what came to be seen as the managed care revolution. Actually, when the original book that I wrote, the term managed care does not appear. And when I look back in writing the epilogue, I discovered that the term managed care came into use just at the very time my book came out. It was, in effect, a crystallization of a lot of the changes in organization that were just beginning to emerge. HMOs had been around for a while. President Nixon had championed HMOs, and really, think about it, health maintenance organizations. What a wonderful idea that was. It was typical, really, of a whole series of innovations that came along, always with an aspirational name. Accountable care, integrated delivery, so they're all aspirational names. They also typically have acronyms with 3 letters. This is the characteristic pattern. We've had waves and waves of these over the years. But HMOs had been held up in their development in part because the capital investments required for the staff and group models that were the original models, really, had been a problem. And in the 80s and the 90s, a shift toward network and IPA models and the development of PPOs helped to propel managed care growth. And there's no doubt that HMOs in particular, managed care more generally, achieved savings in hospitalization. And the rise of managed care coincided with and promoted the development and the diffusion of new technologies that made it feasible to move procedures out of the hospital into ambulatory settings, and that produced an excess hospital supply, and that gave managed care plans more leverage in negotiating hospital rates that helped them to keep costs down. But a crucial factor in this whole process was really that HMOs and other managed care plans attracted more favorable risks, and in doing so sent the traditional forms of fee-for-service coverage into a death spiral. The mid-1990s did see a temporary easing of healthcare costs, and in retrospect, excessive optimism that the whole problem had been resolved. But the rise of managed care also set off counter-reactions. This is part of the whole chain reaction process. It set off that managed care backlash, which led to the relaxation of a lot of the managed care requirements. It's partly through legislation, partly through decisions by employers and insurers. And then also that change in the 90s led to a reaction from providers, which took the form of growing consolidation so as to be able to dominate local healthcare markets and resist pressure from the buying side. Now, so by the turn of the century, this first cycle in the institutional chain reaction was over. A number of experts pronounced managed care dead and buried. The future, they said, would belong to the consumer. Now, in fact, managed care hadn't really died, and the power of consumers would prove to be limited. But indeed, a new phase was beginning, this second cycle. So there was a new round of cost increases in the early 2000s, but it led to different responses from employers than in the previous 2 decades. Instead of trying to make ever stronger use of the managed care arsenal, tightening up those networks ever further, employers in the early 2000s sought to shift more of the risk to workers. And public policies enacted at that time also sought to make consumers more responsible for costs in the name of empowering them to make their own choices. Now, the changes among employers also fit into a more general pattern at that time. This is a period when many employers, for example, are shifting from defined benefit to defined contribution pension plans, another move to shift risk to employees. Shifting the risk for healthcare costs had 2 principal aspects. First, many companies eliminated health benefits entirely for many workers by making greater use of independent contractors, part-time employees, and other arrangements. From 1980 to 2000, the proportion of Americans with job-based health insurance had already slipped from 71% to 67%. By 2010, it would fall another 11 percentage points to 56%. We really have seen a tremendous erosion of job-based coverage over this last 3.5 decades. Second, companies adopted plans with increasingly high deductibles, encouraged in part by incentives for tax-favored health savings accounts. And about a quarter of employees now have high deductible coverage. And just as HMOs attracted more favorable risks in the 90s, so these high deductible plans also attract more favorable risks and have the effect of sending other kinds of plans, low deductible plans, into a death spiral. So it's a repeat of the same phenomenon, the same pattern in insurance markets that we had seen before. Well, the decline of job-based health insurance highlighted all the problems in the non-group market. And that became a core concern of those who were concerned about the problem of the number of uninsured. The number of uninsured grew steadily over this period up to about 50 million by 2009. In the light of the lessons that reformers believed they had learned from the defeat of the Clinton plan, they were very anxious to avoid another defeat and instead to work with trade organizations, to work with the hospitals, the pharmaceutical industry, even the insurance industry, on some kind of a compromise to overcome the blockage of reform. And they were encouraged tremendously by the reform program in Massachusetts that Governor Romney introduced in 2006. And that led many reformers to believe there was an opportunity for bipartisan reform. Bipartisan reform, not as ambitious as what the Clinton plan had attempted to have. This was going to be focused particularly on the near poor through an extension of Medicaid, and others who were unable to buy insurance in the non-group market through reforms of that market and through tax credits. But alas, it was a bipartisan compromise with a moderate Republican Party that at the national level no longer existed. So it was enacted exclusively by Democrats, and ever since, rather than seeking to fix the continuing problems in that individual market, Republicans have been absolutely intent on repealing both the Medicaid expansion and the entire structure of the ACA. Well, regardless of what happens in that battle, the developments of recent decades have reconfigured the healthcare industry. And I just want to emphasize a few key points about the changes that we have seen over this period. One of these involves what was an original concern of this book, The Social Transformation of American Medicine, the shift from professional to corporate control. Now, physicians have scarcely been passive spectators to the changes of recent decades, but the medical profession as such, its collective organizations, are just one of many interest groups in healthcare, in a much bigger and more complex healthcare arena. And physicians individually have, in fact, lost much of the autonomy and control they formerly had as a result of the whole series of developments, the development of managed care, the rise of big healthcare systems, the increased use of metrics to track physician behavior. It's partly the result of development of information technology, the quality movement, all sorts of things have combined. Also greater patient access to online healthcare information. All of these things have in fact reduced that extraordinary position that physicians had through the mid to late 20th century. But physicians have not, in fact, seen a general decline in income, though there are enormous differences in the economic position of different specialties. And once patients are in the healthcare system, they still depend on physicians as their advocates and agents. And in that respect, the position of physicians remains crucial. They are gatekeepers to insurance coverage, they're gatekeepers to prescription drugs. That gatekeeping and advocacy function has not eroded at all. The consolidation of ownership and control in local healthcare markets is one of the most dramatic shifts of these past 35 years. And it has produced higher kind of stratification among healthcare providers, increased inequalities in power, payment, and resources among providers at the community level. As a result of changes over this period, private insurers now pay hospitals and physicians drastically different prices depending on their negotiating clout. The distance from the top tier of must-have hospitals and physician groups to the remaining standalone community hospitals and solo or small group practitioners, including safety net providers, is greater than ever. So although we've had various measures like incremental expansions of Medicaid, the adoption of CHIP, 1997, some of those things certainly have improved access for people with lower incomes, and the Affordable Care Act, of course, as well. We've had this other process that has produced even greater stratification among community providers than used to be the case. Finally, ever since the debate about the healthcare crisis in the late 1960s and early 70s, a long line of critics has offered more or less the same diagnosis of what's wrong with healthcare. The healthcare system, they've said, is so uncoordinated and fragmented that it scarcely deserves to be called a system at all. And for nearly half a century, much of the energy of reform has gone into innovations intended to overcome that fragmentation. And some of the best known of these reforms have really been variants on the same theme. The original prepaid group practice plans of the early 20th century became the health maintenance organizations, which became managed care, which became integrated delivery systems, which became accountable care organizations, and so forth. It's this cycle of innovations with new names and great hopes that has repeatedly not borne fruit. The model alternatives still remain exceptions to the prevailing patterns of care, while the healthcare system as a whole has become more specialized, more fragmented, difficult to navigate, and costly to run. Given the schedule for publication of Social Transformation, I had to send the epilogue to the publisher just after last November's election. And under the circumstances, I had no way of knowing, what was about to happen. I didn't want to make any forecasts that would be disproven by the time the book came out. But after noting, I just added 2 sentences. After noting that so much in healthcare depends on political choices, sometimes on a single vote on the Supreme Court, sometimes a presidential election, I added this one point. While public policy can be socially inclusive and economically rational, it can also be constricting, cruel, and chaotic. Well, the chaotic part is for sure the case. We have had chaos in health policy for the past 8 or 9 months, but I can't imagine. This is how things are going to settle out. This is where we're going to end up. So the great chain reaction isn't over. The political divisions are as intense as ever. The stakes are as great as ever, the moral stakes as well as the economic ones. There still isn't much public trust, either of the healthcare industry or of those on either side who want to change it. So the challenge is enormous to reaching some kind of agreement and moving things forward. So I'm not able to distill a simple lesson. I don't have a 3-letter acronym that I'm offering today as the next solution. But I'm certain we won't improve healthcare unless we understand the past.